Well, Rich, I think we'll get started. What do you think? It's about ready to go?
All right, what do we got? 77 slides. So thank you, Guy, for putting this beautiful PowerPoint together. So welcome everybody again. If you're watching this in 5 years from now, remember that we're recording this in 2017. As we do this, so you always got to keep that in mind. I watched, listened to a podcast the other day. A guy was like 7 years old. I was like, what are they talking about? We're still doing that. So
yeah, we do record all these, put them on our YouTube channel, and we hope you get a lot out of it. And again, thanks for time stamping that for us in case things change. But I'll tell you what hasn't changed, unfortunately, certainly if it's changing, it's not going in the positive direction from a healthcare standpoint, is the number of adults with obstructive sleep apnea. 1 in 5, 20%. And I think we're starting to see this number even maybe go higher. That's a pretty, wouldn't you say, Rich, conservative estimate compared to some of the newer studies coming out that 1 in 5 adults has obstructive sleep apnea.
Yeah, it's scary. We're all getting fatter. We're not many of us are getting skinnier, so that's why that number is getting worse.
One of the reasons.
Some parts of the country it's probably a little worse than others when we look at the demographics of who's overweight and things like that. But what's so significant about 10% there is those are all the people that we've identified out of this huge chunk of people. We just said 1 in 5 adults in the United States has this problem, and only 10% of those who have sleep apnea know they've had it. So, and then how many of those are using CPAP successfully, Guy? Not a whole lot of them, right? So
yeah, I mean, we estimated if you say 1 in 5 adults has this, only 10% know. How many actually have an open airway every night, all night long? Most of those on CPAP. Hopefully we're getting more and more on dental devices. It's 1 to 2%. I mean, 3 if you really want to get aggressive. And something we've been saying for years, and I've not heard anyone come up with any rebuttal to this, obstructive sleep apnea is the most undiagnosed, untreated serious medical disorder in our country. I mean, that's a pretty bold statement, but it's true. And this slide, Rich, was from a study of, 5-6 years ago. $4 billion with a B is spent on CPAP alone in our country annually for obstructive sleep apnea, and that's to help 1 to 2% of these patients really totally effectively treat them. I mean, there's maybe some others that are partially treated with CPAP and other methods, but that's a huge number. So I think we just thought we'd throw that out at the beginning because we're talking about dental devices, and is there a place for this? I mean, this is what we were asking ourselves 15 years ago. Wow, this is great, it's fun, but is there a place for dental devices? And I think these practice parameters, Rich, when they came out, is what really changed our focus on in my practice and yours as well, I believe, right?
Well, it certainly gave some credence to what we were doing already, Guy. Guy and I have both been doing this a couple of decades now, almost. So that's why we said we've learned a few things along the way, and we made a lot of mistakes. But Guy talks about this as the day the earth shook, in dental sleep medicine, because a lot of physicians are like, well, what's the deal with these dental devices? And as even dentists, we don't know that much about it. So it takes time, but this is now over a decade ago, Guy. I mean, in some ways it seems like it was yesterday, doesn't it?
Right. Yep.
But in other ways we think, wow, this is a decade ago. So remember, for mild to moderate sleep apnea, we can use these dental devices as a first line of therapy. If they're severe, the patient should at least think about or attempt CPAP first. And as a dentist, the dentists are really the people that should be doing this.
Yeah, and if you can't wear the CPAP, we used to cut out the patient's uvula and do surgeries, and now the standard of care, and again, these standards I want to emphasize are from the American Academy of Sleep Medicine. The physician standards state if you can't wear CPAP, you should have a dental device as your next line of therapy, or again, mild to moderate. And there's new standards that came out last year, which are very much in line with this. So we wanted to start out with saying, dental devices, that's what this webinar is about. If we're talking about something that only 1 in 10,000 patients needs, then we're maybe wasting a lot of time with you. But 1 in 5 adults could use your help, certainly at least understand that they have this problem and possibly treat them. So Rich already mentioned, we've been doing this a long time. I'm Guy Yatros. Rich Drake is my partner, been my partner for long as I can remember almost now, but we've been doing this over 30 years between us. We've done thousands of devices, and we live to help patients who is what we focus. It's all we do is help patients treat their apnea with dental devices and provide systems and tools and education and help other dentists who want to succeed and provide this service in their practice. And that's what our mission statement is for Dental Sleep Solutions and what we call the DS3 experience. I know Rich always loves our mission statement because we put a lot of time and effort into developing it, because it really comes from where we want to be and what we do.
Yeah, we're the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine, period. So it only took a combined 600 IQ points all day to figure out that mission statement, but at least we got it. And we've actually stuck with it for a few years, and we believe it is true. So you don't have to reinvent the wheel. You know, if you're new to dental sleep medicine, you're going to learn a whole lot tonight. If you've been doing dental sleep medicine, you're still going to learn something, you know, because we do a lot of devices, man, and we see a lot of things and a lot of different patients, and we're kind of getting a really good feel because there's not a whole lot of literature out there right now that says, hey, with this patient, we tested these 10 devices and this one worked better. You know, there's really nothing out there that I know of that says that stuff. But we do, we help other dentists do this, and we teach a lot of courses too doing this. Yeah,
that we do courses. If you like what we talk about and you want more practical, hands-on, and we teach these courses, they're listed here. We are adding to it. If you are interested, just type course into the question box. By the way, put your questions in the question box. We're answering them as we go. We have hundreds of people signed up this evening, so we can't open up the mics, but we will answer the questions as we go along, try to get to all of them, either verbally or through the text box. So type them in there. And if you're interested in coming to course, just type course. If you know the city, go ahead and put the city, and that'll secure you $100 off the fee to come to our one-day course, or a few hundred off our two-day courses. But we'll show those at the end. Again, also we have a symposium. Wow, that was fun last year, wasn't it, Rich, with all the wonderfully brilliant people that we had in Clearwater Beach?
It was a lot of fun. You know, a lot of dentists, a lot of staff there. We had a lot of vendors. I would say it was just, you know, it was our inaugural symposium event that we did last year. And, you know, Guy and I were a little bit scared we might throw a party and nobody showed up. And instead we had, you know, 400 or 500 people there. So, yeah, we're going to do that again. We've got a good lineup of speakers. And what we focus on is the hands-on fundamental, you know, how do you actually do this and do it better in your practice? That's what we talk about at the symposium. So I think you'll get something out of it.
And lastly, this is what we do. DS3X, people ask what that is. That's the DS3 experience. We help with what we call the 4 pillars of dental sleep. We help offices screen, test, treat, and bill. We do that through education, coaching, software, and support. So we're truly the only company like ours out there that help dentists, that we have a whole faculty full of team members that come in every day to help dentists succeed. And if you're interested, you have challenges after this, if you have more questions that we didn't get to, just type in free consultation, and we'll be happy to, one of our trainers, to meet with you at no cost, to just find out what your challenges are, tell you how we can help, and answer your questions, even more importantly. So at any point, type in free consultation, and we'll let you, we'll be happy to, one of our trainers, to schedule a time to sit down and over the GoToMeeting or phone and talk to you about how we can help answer your questions. Lastly, the meeting, again, I mentioned, the next one of these webinars, we're going to really talk about one of the more important steps. How do you get a patient from either not knowing they have apnea to knowing and then helping treat them? But we need to have the right systems in place, the right verbal skills in place, 3 vital pieces we'll talk about that you have to have. And if you do these things right, you're going to see a lot of patients for dental sleep. So let's talk about treatment, Rich. I think today is one of our favorite topics because I think the dentist, it's in their comfort zone, even more so than some of the other dental sleep topics that we talk about.
Yeah, we call those the four billers, you know, the screen, test, treat, and bill. And, you know, I think, Guy, it's the only one that's in the dentist comfort zone, you know, at least initially, because we like, you know, hey, here's my device, right? I got to put my hands on it, you know, and I can adjust it and I can do it. So, but even this, you know, most likely we started this, Guy, how do we, you know, which device do we make? So let's back up just a little bit. When we're going to make somebody a bite, we got to talk about, we're going to make a dental sleep device, and we got to have a starting position. So we could spend a whole hour on this if we wanted to, Guy, but let's just say start forward and comfortable, and that's probably all we'll say. I like the Pro Gauge, the one on the right. Guy, you like the other one, don't you?
George Gauge, yeah, and both of these work the same way. There's plenty of videos. We can point you towards those if you contact us, if you can't find them readily, on how to use these. And these two gauges help you measure the range of motion and help you set that bite at I like the way Rich puts it, at a forward, comfortable position. Because as you're going to see towards the end of the presentation tonight, it's not that important where we start them, because we're going to walk them forward until we reach our goals, which we'll define as we go along tonight.
Here we go. Let's talk. We're talking about these devices, you know, the Dorsal, the DreamTap, the Herbst, and the EMA. So there are a lot of devices out there, okay? And what do we tell people, Guy? Just pick one, man, and make it. You know, we don't like these dentists that aim all the time. You got to start. I guarantee you, if you show up at your office tomorrow morning and you get your staff together and you go, okay, who sleeps with somebody who snores?
Right.
Somebody in the room is going to raise their hand. Start on that person. And I love this slide, Guy. Show this.
Yeah, I mean, I think the point is here, we're going to get into the details on those four devices, who they work better on and so forth in just a bit. But I want to emphasize, this is not a complex problem. This is all there is to it. I mean, the patients fall asleep, their airways collapse. And I'll replay that again to show, I mean, when you look at this, you know, it's the tongue falling back. It's more complicated. It's three-dimensional. But really, all we're doing is the airways collapsing. And what are we doing to fix that? Well, I think Michael Phelps figured that out. Look at him swimming. I mean, do you think that somehow he's figured out his airway might be a little more open, and he may get that 1/10 of a second edge to win all those gold medals? Look when he finishes. My son, Rich, you know, my son, he pointed this out to me. He said, "Look at Phelps. He looks like he's got one of your devices in, Daddy." He was about 8 or 9 at the time when he pointed this out to me. He's 11 now, but look at that. I mean, why is he doing that? Either consciously or subconsciously, he's opening his airway. And really, when we talk about these devices, there's bells and whistles and pros and cons, but all we're doing is opening up the airway by pulling the jaw forward. And this, these are what MRI on sedated patients, and we have before and after on the left. Let you describe it, Rich. You've been using the slide for years.
Yeah, you know, the before, if we look at it from, you know, from the back side and we look at it from the top, interestingly, Guy, we would think that when we grab a hold of the jaw and we move it forward like that, we would think that we would be making the airway bigger front to back. And that's not necessarily the case. That may be a little bit that way, but the interesting thing here is, because of this is a very complicated three-dimensional shape, we actually make the airway bigger side to side as well. All I can say, Guy, is I'm glad it works, because I have a job and I can make a living at this. So
yeah,
we don't have to overcomplicate this either.
No, we don't. I think that's what happens a lot, is we overcomplicate. All these devices do well at opening up that airway, both really laterally a lot more than we ever dreamed, even more so sometimes than anterior, posterior. But what does it matter to us? It matters that more air gets to the lungs. And that's all we care about. So choosing the correct device, you know, we've spent hours talking about how we decide, and we've debated. We've had heated debates and arguments with our colleagues about this, and then we finally agreed that this way works just about as well as any of them.
Yeah, just put them up on the wall and throw a dart over there and see which one sticks.
You know, and I think that will work almost every time. I mean, because all these devices work, But you know, we're not going to end and say thanks for your time. We're not going to help you, I promise. But we want to go back to what Rich said. Relax. Just go start doing these. You know, they all work. What do you say, Rich? Something about a better device? I like the way you say that.
Yeah, I like to teach, Guy, that you can't make a wrong device, but you can make a better device. And that's what we want you to get over tonight. So that's the relaxed part. You're not going to make a wrong device, but we want to teach you how to make a little bit better device based on some things that we can look at and we can measure. And now we can make an informed decision that helps us be a little bit more successful.
Yeah, and Rich and I mean, we kid a lot, but we have put a ton of effort and time. We've done thousands of devices. And so I kind of had my way of doing it intuitively and maybe systematically, and Rich did as well. And so we said, well, what do you look at, Rich? And we polled our other colleagues who've done a lot of these. And we started looking at, well, we start with an exam and we look at various things that make one device stand out a little bit more than others. And I'm going to pull this back up a little bit for you. Pull this back up a little bit later, but we put together in our DS3 system what we call our device selector, where we take those items and we look at bruxism, tongue, some of the things we're going to go through, and you can slide your little sliders back and forth, and it will sort the devices in a way that can help based on these items that we're going to tell you to evaluate. I hope that you still realize no matter how simple we try to make it, because that's kind of our motto at DS3, is we try to make this simple because everybody gets kind of confused and we try to simplify everything. No matter what, this is what Rich, when I first met him, yeah, Guy, I'm going to give you this advice, but you know, no matter what, you still got to use your brain on occasion. So we'll make it as easy as possible, but you're still going to have to think just a little bit.
And in the meantime, what do we like to say, Guy? Fake it till you make it. You know, you at least got to sound like you know what you're talking about. And that's what a lot of that consultation talk is going to be on in a few weeks when we do the next one.
And we'll give you some real good information as well. But yes, acting like you know what you're doing sometimes is important. So we're going to go through each of those items that we look at. So I had a picture of an exam up there a moment ago. And so when we're doing our dental sleep exam, we're doing it for documentation and a lot of other reasons. But today, what we're talking about, the component of the exam that we're talking about is that we're evaluating certain things to determine which device might be better tolerated, more comfortable, maybe even more effective in some cases on certain patients. So we're looking as they open and close and looking at their teeth. And one of the first things we're going to look at is their tongue. I mean, their tongue, is it big? Is it large? Is it small? Is it scalloped? Is it going into the airway? With certain devices that have hooks and so forth, is that going to be bothersome? Do we want to make a little more room for the tongue? So I think really we're going to go through a lot of these. I think tongue is certainly one of the higher priority things that we look at. Anything you want to add on that, Rich?
Only thing I would add is that looks like a really big tongue there.
It does. It does.
So you got to document, you know, joint problems. I think this is probably the single biggest thing, Guy, that I see scare dentists off. You know,
Yes.
Yeah, I want to make the right device. I will tell you that what I've been saying for 20 years is that mandibular repositioning devices make the jaw feel better. The last 5 years, we now have 4, 5, or 6 studies that are coming out that say the same thing. So, you know, very, very, very seldom will a dental device make a TMJ worse. But you got to, you know, ask questions, you know, open your mouth. Does your jaw click and pop? Does it ever? Oh, yeah, it used to a lot, and then it quit doing it. Just write it down. You know, I can't tell you how many times, Guy, no sound, no click, no pop, nothing. But yeah, it does it sometimes. And then, you know, 3 weeks into treatment, the patient goes, you know, my jaw's clicking now. I go back to my notes and I go, yeah, you said it does sometime. They go, oh yeah, you're right. I forgot about that. And then like all of a sudden, it's no big deal, you know? So ask, listen, palpate the muscles, at least the master, the temporalis. If you want to put a glove on, you get your little finger up there, you look at the pterygoids, you know, the medial and lateral, maybe, you know, submandibular, the sternocleidomastoid. So, and then we're looking at range of motion. We talked about the George gauge and the Pro gauge. There's a couple other different ones, but we want to look at range of motion as well. So this doesn't take too long, Guy, but sometimes it should take a little bit longer. You know, as we learn about this more, we need to be careful about this, but do not let this keep you from moving forward.
Absolutely, and I agree with everything you said. And as we're going through this, again, we're doing this with thinking about which device we're going to do. So as we get to these 4 devices, certain devices that maybe only fulcrum off the front teeth may put more pressure on the joint. So if there's a joint problem we're concerned about, maybe we don't want to do that device. In contrast, if someone has a muscle problem, they're doing a lot of clenching and have muscle discomfort, we know if you only hit in the anterior region and the posterior is discluded, that it tends to put less muscle activity on the patient. The patients tend to clench with less force at the very least. And so maybe we do want it to hit in the front. So there's things as we're looking at this to the opening. Some devices allow you to they're bigger and can get in. Other ones open wider. So we're thinking about which device. We're going to tie this together in just a little bit. So looking at this mouth, I mean, this patient opens quite wide. And so we're not limited to devices that are smaller to fit in this patient's mouth. The contrast may be true. They open so wide that certain devices may become disengaged, and we may think about not using them or other options those devices offer to prevent that from happening. Which teeth are there, which are missing, how far can the patient move their jaw? Maybe we want smaller increments during our titration period. So we want a device that has smaller increments as we go along. And then retention, can you always get good retention? I mean, this patient here has got, you think you could get one to fit real tightly in this?
No, I don't.
Right.
Little short, tiny teeth with no undercuts, and they're very straight. How do we get something to fit on those teeth? It becomes harder. I think, Guy, I do a lot of these things, man. I mean, all day, every day, I'm doing consultations and giving devices and doing follow-ups. And I will say probably the hardest thing we do day in and day out is just getting the tightness right. It's too tight. Oh, it's too loose. It's too tight. Some people, that window's about like this. You have to pay attention to that. So the longer the teeth are, the more crooked they are, the more undercuts I have, and therefore the less I'm concerned about a device staying in. Now, when we get to this, I know I'm jumping the gun here a little bit, Guy, but this is how we're going to use this information, because we're going to give you the different dental devices and we talk about the pros and cons. So with this particular patient, for example, if I had a device that was hooked together like a DreamTap, it becomes very difficult to keep that in, because every time they open, they pull it apart. But if I have a dorsal here,
right,
or a Herbst, now I can get that to stay in a little bit better. But I know I'm getting ahead, Guy, but I wanted to let people know how we're going to use this information in our exam.
And one thing when we teach our courses that I always ask, and I don't know if trick the audience is the right way of putting it, but hey, do we want our devices to always fit tightly? And everybody's hands raises up. Yeah, of course we do. Then I say, well, what about if they have, 4 5-unit bridges with 3 Ponix high water gold design that GV Black himself made? Do you want them wrestling this thing and snap? Sometimes we want these devices to fit quite loosely because we're worried about the teeth underneath them. And then we'll talk about which devices work better, kind of Rich already gave you a clue on here in just a few moments. So retention can be a problem, but there's also times where retention, we don't want it due to the stability of the teeth. So I think that's one of the important things as well. And bruxism, I mean, gosh, we're going to take a little segue into bruxism here. And I'll just start by saying, if you want your restorative practice to be more predictable, the number one thing you can do is to learn more about bruxism, how it relates to airway problems.
Amen.
I mean,
I love the way you said that.
I think it's the first time I've ever said it that way. Someone, like, we're recording this, I'll go back and review it. But, I had a restorative practice. It's been a long while since Rich has done restorative, and did a lot of complex prosthetic treatments. And my challenge was always breakage. It wasn't decay typically. It wasn't function. It wasn't even aesthetics. It was, you do this big case and then it breaks. And in retrospect, I was taught differently about bruxism than maybe what we know now. And what we know now from the sleep experts, so this comes from some of the sleep experts, which you all may not be as familiar with. It's the most revered book on sleep ever written. It says that apneic patients, OSA patients, are 2 to 3 times more likely to have grinding in their teeth. And they think it has to do with not sleeping well, or these microarousals. And we could talk for hours. Maybe we'll do a whole webinar on this about how that maybe it doesn't have much to do with what we were taught, that it had to do with, you know, posterior interferences. And there's other information out there showing that we're starting to really believe that a lot of the bruxism problems that we have at night are due to sleeping poorly. In other words, microarousals. And there's not a whole lot of evidence showing that these grinding at nights are due to the fact that we made a cuss tip a little too high. And if you start learning about that, maybe you don't believe me, but Rich, when this came out, I was like, aha, this, I could have predicted this. You're familiar with the study, or you want me to go through it?
Not as well as you are, Guy, because again, I haven't done a filling for 16 years, but don't tell the State Board of Texas, Dental State Board of Texas that. Yeah. But I have heard Guy say for more than a decade, I've heard you say, man, I just did this full roundhouse on this guy and everything. And man, he keeps breaking it. And it's like, you know, I mean, you call Pete Dawson himself and say, hey, I'll pay you $10,000. You come down here and, you know, find a balancing interference or something like that. I've heard Guy say that for years, but this kind of confirms what you've been saying, Guy. Yeah,
I mean, it's a moderately sized study of 67 patients, and this is all implant supported prosthetics. And you know, you can go back and review this, and we're happy to point you to this. If you, again, you want a free consultation, just let us know and we can answer any of these questions. But the bottom line on this is 92% of the cases in general with restored with implant supported prosthesis are successful after, I think this was 3 or 4 years. In this study, only 19% success, so 81% failure, either porcelain screws, what have you, on the apneic patients. They had a substantially higher failure rate than the non-apneic patients. And so, you know, we'll leave you with that information, and maybe we'll do a course on bruxism here coming up. But I think at least it hopefully intrigues you enough to realize that airway, in some cases, and I might even say many of the cases, contributes to bruxism. We should at least be aware of what's going on. And we want to select the devices that hold up to bruxism well. So when we talk about the devices in a few moments, if we open up their airway, we may help their bruxism in some cases, which is great, but we still want to protect ourselves and make a little sturdier device that maybe allows them to brux but holds up at the same time. So is this your dog, Rich? I don't know where we got this picture.
And the other thing I want to say, Guy, I'm pretty sure there's some dentists out there that just took a pen out of their pocket and they wrote down some patient's name, like, oh, that's probably Mrs. Smith's problem. You know, we need to get her sleep tested. So that's exactly right. But when we look at bites, you know, how deep, how shallow they are. So, you know, class 2 bites are usually deeper, but not always. You know, can you bite on your back teeth? So again, this is something that we look at when we consider which dental device we're making. And that's what we're doing right now. We're going through this stuff. I think, Guy, one of the most important questions you can ask is, can you breathe through your nose?
Yep.
So will you do me a favor, Guy?
Yes.
Will you show them that really fancy special test I showed you?
Yeah, so we ask them if they can breathe through their nose. And this test that I'll show you that we do to evaluate nasal patency is, you'll like to practice it some, but you'll get it down. So you just ask the patients, if you don't have the web camera on, I apologize, but you tell them to breathe deeply, like that. Okay, take a big deep breath. Now, okay, do it again.
Yeah.
Can you hear the difference?
Which side?
Yeah, which side? You know, of course, I'm a perfect example of poor nasal patency, and so it works out well in the demonstrations. But you know, you really do just clog. You know, just compress one side, compress the other. Evaluate their breathing, both what you hear and see, and then as well as what they tell you. Certainly, you could evaluate it with CBCT if you want to look up there with a scope and you feel comfortable doing that. Other ways, but that test alone is a really essential part of our exam, because absolutely, whether you can breathe through your nose or not, it has an effect on how well any device will work, number one, and CPAP as far as that goes, and also which device we choose for sure. So we'll be going over which ones are which in just a few moments, and then. And this is, I'll let Rich describe why it's important, but we took one of my typical Florida patients here. and talk about some of the unique challenges they have. I mean, do you have patients that have some troubles with the devices at times, Rich?
Yeah, what we figured out, guys, it doesn't matter how many times you tell somebody this is where you put the key and you turn it. You got to tell them 5 times before they remember how to do it. So make videos, we have them on our website, things like that. But, remember, a dental device got to be comfortable, the patient, before the patient will wear it, and then they wear it. And this is just going to save you work. If you teach the patient how to adjust the device and you give them a little schedule and we give them a little sheet, hey, this is your titration schedule. On this day, you're going to turn this screw 3 clicks or whatever, it is. And because otherwise they're coming back to your office and they're asking you to do it and all that other stuff. So yeah, keep that in mind, when we talk about the EMA device, for example, how do you get that rubber band on? If somebody's hands are moving like that, they might not be able to do it. Do they have a caretaker who can help them? So just remember, use your brain.
Yeah, use your brain, because it's not only adjusting the devices, getting it in and out.
That's right.
And the EMAs we'll talk about, the rubber bands can come off, and they're going to have to put them back on. So let's talk about that and how much they cost. I mean, these devices go for a few hundred at the lowest to mid. I think some of them over $700. Most of them are in the same range. You do this how you want. We typically charge most patients the same because they fall in the same range. And I don't think I typically make a decision saying, well, this patient doesn't have as much money or as good insurance, we're going to give them this device. But just be aware they do cost different amounts. And the DS3 has, as members for our organization, you do get some discounts that really help out with that as well. If you're all interested in learning more, let us know. So here is what we went through. And we digitized this in DS3. That's one thing I think we're pretty proud of, that we went through and took all that information and made a computer program that helps that process, but we still hope that you understand the process and use your brain some on it as well.
I love that little program we spent all that time on, though, Guy, because you take each one of those little sliders and you just move them if somebody's a severe bruxer or they're not. So, and what that does is it kind of ranks them for you. And I think if you use anything in the top 4, 5, 6, 7, you're probably okay. But again, that's what we just did, was we went through there. Okay.
Yeah, and one thing I'll mention is don't look at this and say, well, this one of the top's the best or the next one. It depends on the case. And so we just threw an example up there. We're going to talk about the 4 devices after we talk about more general the underlying surface of the device. There's really 3, maybe 4 types of devices. Most of them that we use are, so they're acrylic on the outside. Some of them have metal, which is fantastic, make them stronger. But the underlying part, what touches the tooth, there's different materials you can get them in depending on the device and depending on the lab. And so the first one we'll talk about is just all acrylic. And this one dentists are familiar with. You're used to it, you can adjust it. One of the advantages to it is it can be thinner because it's just as thick as the acrylic. You don't have a liner in it. And I think the biggest advantage is dentists are used to acrylic. They can grind on it, they can add to it. They probably have acrylic in their office that they're used to. And the acrylic basically comes most of the time either all acrylic, that the acrylic itself gets into the undercuts, or as you can see, some of them have these ball clasps that have the advantage of you can tighten and loosen them, but they have the disadvantage that those get loose over time and you may have to retighten them. And also be aware those can cause teeth to move, especially if you don't wrap the very back of the back molar. But if you wrap the back of the back molar, we're typically okay. So acrylic's always a good choice, one we use a lot. We have 2 other ones. Rich, any more on the acrylic? And I'll move on to the next.
I just thought of this, Guy, but you could probably get it repaired at your local nail salon as well, if you had a little crack in it or something like that.
Well, I mean, you're joking, but you can repair these yourself much more readily. If you're not comfortable, your local lab might say, oh, I'll repair that for you. We're familiar with acrylic. That's the big advantage to acrylic, and it holds up fairly well. Flex material, go ahead, Rich. I mean, they call it different words, right? But
yeah, so remember there's an outside and an inside to these, like Guy said. So we're talking about the part that touches your teeth, so you can have acrylic all the way through. You can have acrylic on the outside, and then you can have this flex material. Some of the people call it a dual laminate, a triple laminate. They call it Durasoft, Flex. What else is out there?
Comfort Fit.
Comfort Fit. So there's a couple of different things that they're found. I made myself, Guy, about 20 of these devices.
Yep.
And I think I like this one probably better. It's got a little tiny bit of a spongy feel to it. It does flex a little bit, and that sponginess gives it a little bit of that shock absorber type thing. It can discolor over time. You know, if a guy puts it in and he goes, oh man, I'm thirsty, and he drinks one of those nasty green protein shakes or something like that, you know, and takes a drink of it. So you don't want to do stuff like that. But it doesn't last quite as long because the bond between the outside and the inside can delaminate over time. It is a little bit more difficult to adjust, Guy, because, you know, as dentists, we like to grind on things, and this is one of those things that kind of gunks up. So we use slow speed. We grind a little bit, and then we have a stiff bristle brush to get rid of, you know, that little bit real quick. So we've got a couple little tricks like that that will help. But again, this may be the material we want to use, but you got to use your brain. That's why we're talking about it.
Right. And so again, the most comfortable, I think, for most people, and really good for very diverging teeth, because it can flex around the undercuts and get back in them without holding up. So the only two things I would add, and the devices have to be slightly thicker for both that material and this one, because you have to have room for the acrylic and the underlying lining material. And you know, thermacryl, I've been hearing Rich talk about thermacryl for my as long as I've known him, and you know, I kind of didn't like it when I first tried it because of the way the labs prepared it, but they're much better at it now. And I've seen the light. I love this material, and since it's Rich's, I think, favorite material ever made on the earth, I'll let you talk about it, but it's a wonderful material in the right situation. Rich, tell us, sir.
Guy, just because it's holding the transducer on my bass boat together, and, you know, have a chunk on my windshield, you know, that broke off, I fixed. So, you know, this is a thermal plastic that when you get 160 degrees in a water bath, it gets clear and it gets sticky and moldable. You know, so if you think about what that is in that that dorsal dental device, you know, laying in there, you put that in the hot water bath, and then you push it on the teeth, and it kind of grabs on. You can kind of pinch it interproximally, and you can let it sit there for a little bit, and then barely tease it off and push it back in, let it sit there a little longer. So if we want to make it tighter, we let it stay in a little longer. If we want to make it a little looser, so you know, it fits. We can always make this thing fit. What if we got 3 or 4 crowns on this side and a couple fillings over here? This would be a great material to use, because we can go ahead and get started treating the sleep apnea now. We don't have to do that. So we have the ability to do some of that stuff. It does add a little bit of thickness to the thing. It does have a longer learning curve. You cannot put a burr on this and grind on it. It
Right.
will gunk up, and you'll cuss and, you know, throw your golf club out the window. So, but how we do it is with a scalpel. Just get a new scalpel blade and do that. So it can stain a little bit too, Guy. You know, we've seen that kind of thing, but maybe not quite as pretty. It does pick up a little more odor even, wouldn't you say, Guy?
Yep. Yeah, I tell patients, look, this is kind of an ugly material. It may stain. It may not look great after a couple of years, but the advantage is I can always make it fit. I can always adjust it if you need dental work done. So it's a great material. So, I mean, between the 3 of these, that's the majority of what we do. There's other materials. There's, you know,
Bruxy stuff.
Bruxy's nylon materials that are 3D printed. There's other ones out there. And we're not saying that we never use, we use those on occasion, but we want to just kind of give you the what we do the most. And so those are 3 materials we use the most, and these are the 4 devices we use the most and when. And the dorsal device, I would say, for me personally, is one of my favorite, maybe because I personally wear a device every night, and this is the one that I prefer. The various forms of this one, and it's called a dorsal because you can remember it if you forget the name of it. It's named after a dorsal fin. You can see the dorsal fin here on each of these. There's different designs of these. Let me get my thing out of the way here and get my pointer up. There's different designs of these, and you can see here this has a piece of acrylic that moves the upper a piece moves forward. This one has the wing on the bottom that moves posterior. And other than that, they have some similar features. I think if I close this and click, you'll see where you adjust these. There's an adjustment right Did I do it there? We don't forgot to put the arrows in that one. Sorry. Let me
show these, Guy. Let me show these on my camera.
There you go. There you go.
So this is the Respire one, and that's just the same jack screw that we use on maxillary palatal expanders. So they built in some mesh and little things to help make this a little bit more robust. But there's just a little keyway that you put in there and turn that.
And as you turn it in the direction of this arrow, it's going to move this wing posterior. That's about 1/10 of a millimeter, so very finite adjustments. Same thing here. It moves this more forward. What do we like about these devices? I would say the #1 thing I like is that you can open your mouth. And so 2 of the devices we're going to look at tonight, you can open your mouth. 2 of them, they kind of lock your mouth together. And why do we care about opening your mouth? Well, it's more comfortable. If you're a mouth breather because you have nasal problems like myself, it's less claustrophobic because you can breathe through your mouth. You can make these in smaller pieces because one goes in and then the other one. So if someone's got a limited opening, this is a fantastic device to do for them. It allows us to not have to, what do you say, like your lip liquor. You can, swallow and so forth more easily.
Yeah, and if you're a mouth breather, it's a little bit easier to take a sip of water.
Right.
The other thing too we talked about, Guy, was there's just a little bit of friction against the upper and lower component there, depending on the angle as well as how far forward you might have the patient. And therefore, these don't have to fit as tight.
They can fit quite loosely.
Yeah, they can fit quite loosely and still work very well.
So if we even do these on upper denture on occasion, don't we?
We do.
On a dentist. So any device that allows you to open and doesn't lock in place, well, we can do them with less teeth, less retention. Those teeth Rich was describing earlier to you today. So we'll talk about which devices which patients we use it on more or less in just a moment. We promised we'd talk about some changes in this. So, the Dorsal's been around for quite a long time. Whole U Respire devices have really, I think, raised the bar up a little bit more on their dorsal design. And 2 key differences. One, as we mentioned, their wing is on the bottom. So in other words, it moves back. But what's nice about that is actually the fin stays in the posterior, because as the device moves, the chin moves forward, but the wing stays there, as opposed to the other design, the wing kind of moves more forward and starts poking in the canine area as you advance it. The negative is these can all break in this area and on the other design. And what Respire has done with their Blue series here, the Blue Plus, they've added this upper little wing that comes down that you can maybe see here, and Rich might be showing. I don't know. Don't have your camera on right now, but that little wing in the back. And what it does is it has added around, I forgot the number, Rich, but 300 times more strength, because it doesn't allow that wing to be flexed out and broken near as readily. So
yeah, plus they put some of that mesh in there, Guy, to, grab onto it a little bit better. But remember, that torque arm, the farther that screw comes apart, the more that likes to turn. So what Respire has done is increase the back side of the opposing piece, and it allows a little bit less movement. So we're seeing them break less often. And of course, they have the EF, which is the endurance framework. Right. So again, Guy was talking about size, matters. People have little old tiny mouths and things like that. So, they're waxing and casting this metal framework, and they're just making these, Guy. Like you said, man, it's changing. You turn your head the other way and somebody's doing something a little bit different, and that's what we're trying to do, is help you guys bring that. I have a device that I'm supposed to deliver on me next couple of days, guys, so I'll give everybody some feedback with that.
Yeah, we use these on, I think we've hit most of these mouth breathers, large tongues, minimal teeth, retention issues, deep bite you already mentioned. That's one of the more comfortable and aesthetic devices. And heavy bruxers, I used to say no, never on these devices. This is one of the ones I'd steer away from. If you use the EF Plus, I feel much better. It's holding up much better than the other one. So now we actually have a device that we would consider at least for a bruxer. And the reason we put severe disease here, anytime the device allows you to open, you lose just a little bit of control over the airway. And we could one thing I'll mention, any device that allows you to open, we're always going to have hooks or some way to add elastics between the upper and lower arch, so to minimize that opening, because sometimes when you open your mouth, it causes the airway to maybe become smaller. So as you can see on these Medicare devices, the Herbst we're going to be talking about in a minute, you can see these hooks, and we'll always have hooks on devices that allow you to open, and we always run the risk when they open that they may be a little less predictable, although we still have phenomenal results. Medicare has a list of devices that they approve, and so if you're providing for your Medicare patients, you have to make sure you use a Medicare approved device. We use these two, so when it's we don't need a dartboard for Medicare. If it's a Medicare patient, we're either going to do the DreamTap or a Herbst device, and
we just need a quarter, guy.
Need a quarter, penny, something with a head and her tail on it. So you've been doing taps as long as a lot of people maybe have been involved in dentistry. Maybe some of you people have been alive out there. You've been doing these so long, because you and Keith Thornton go way back. I know, being a Texan as you are, and the new DreamTap. I think we should let you describe how that works and how much you're using that today, and I'll do the Herbst. How's that sound?
Sounds good. So again, the materials, you can get this made out of a couple of different devices. You can use the some labs actually make this out of the Bruxies now as well, Guy. We've tried a few of those and they seem to work well, but you just got to upper and lower. And if you're used to the old taps used to be upside down compared to this. So, they used to be on the plate was on top. So now we've switched that a little bit, and we have a little bit more room for the tongue. So, the bottom part of the plate has a hook on it, and that hooks to the outside wire on the top. Yeah, right there where Guy's got his little pointer. And what are we doing? We're just grabbing a hold of that jaw. When we move that screw, we move the jaw forward and back like that. So again, this requires that the teeth be a little bit more sound in the front. If somebody had 6 implants on the upper and the lower, and you'd restored all their teeth, this probably wouldn't be a good choice, would it, Guy? Because I'm pulling from right there. So you got to use your brain. So my deal with the taps very simply is, can you breathe through your nose most nights? And if the patient says yes, then I know they're a good candidate for a tap. I mean, it's not much more complicated than that. So Keith Thornton has been saying for years that they work better with severe disease. When you look at the best single study that's ever been done, the Hokema study, where he compared dental devices to CPAP in a head-to-head patient age matched randomized control trial, then now we see it kind of supports what Keith has been saying for years. But so we use them a little bit more with severe disease, Guy. AHI is above 30. I like these a little bit more. When we talk about the bite, shallow bite, remember that go back one, or you've got the picture there, Guy. I see it. So remember that the plate and the hook there add some vertical component. So when I say I like to use these less on deep bites, that's because I've got to open 8-9 millimeters to get to here. Then I got to add 8-9-10 millimeters of the device itself. So now I feel like I'm, like that when I've got my jaw forward. And we know that the more vertical I have, the more uncomfortable it is. So more can breathe through their nose, severe disease. We now have kind of that anterior discluding element built into the dental device. So we can use this with big bruxers. And I have used these, Guy, on patients with this just few as 4, 5, 6 teeth in each arch. Front,
as long as they're in the front, yes.
Right.
And the only thing I didn't mention, I don't think you mentioned, there is a little hex wrench that goes in here, and when you turn that, that's what moves that hook about a 1/4 millimeter each 180 degrees. So if you want a device to work, this one's a great one, as long as Rich said they can breathe through their nose. So if it's a Medicare patient and they can't breathe through their nose, or they're claustrophobic, or they don't have the teeth in the right place, then we might, or they're, maybe they're really picky and they're apprehensive about the device, because I'm afraid I drink water all night, and they just seem, a tap's a little bit harder to get used to.
It is.
Then we're going to go with a dorsal if they're not Medicare, and or a Herbst. But if they're Medicare, it's an easy choice because we're going to go with Herbst, because Herbst and the Dorsal are very similar in their pros and cons. They allow your mouth to open, the swallowing, the mouth breathers, the nasal patency issues. Again, I will mention these hooks. Anytime that you have a device that allows you to open, that's fantastic for comfort, but if they open too far, it may not work. So we will add elastics on these if the patients find that their mouth's dropping open. So there's various iterations of the Herbst device. This one we call a double barrel. As you move these screws, one tightens against the other. You turn it, you put a little key in here. I think I have a picture coming up with an arrow, but you twist that towards this arrow and it moves that pendulum over that piston back, and it advances the jaw. This particular one actually has a place that you can move this to here once you run out of advancement, and that even gives you further advancement. So that's your typical. They even make it with one of these little barrels, or this one has a locking one, two of them. I prefer the single barrel over the other ones a lot of the times.
The one I have here with me, Guy, has the single barrel on it.
Okay,
so you can see it just has one of those hooks on it, and that's where that keyway goes. And you know, the nice thing about the EF that Respire has, Guy, I love that little scale down there, don't you?
Yeah, so one of the negatives, as I back up here, is hard to know how much you've advanced this. You can count the turns and you can figure it out, but what they've done at Respire is they've moved the sorry, I thought I had arrows there too. Something happened. They've moved the advancement. I think, Rich, you can maybe, they'll be able to see it on the screen, but now you put a wrench in the posterior X wrench of this, and it's much easier to engage and turn, and the attachment is internal. And then on top of that, as you advance it, there's a gauge. And so it's a lot easier for the patients to advance. It's not as, you don't have to have as good a dexterity. It's easier to keep track of how much you've advanced. And so I love what Whole U Respire has done. Whole U is the company. The Respire is the lab that is part of their company that makes these devices. And I think they've made some advancements in this arm, and because that arm's been the same since I've been doing this, and I really like that aspect. And again, you can get this in the EF, which is, again, for the endurance framework, I think it stands for. Again, it's the metal that makes it stronger. So when do I use Herbst devices? Pretty similar to the dorsal device. I would be more inclined to use this on a severe bruxer. Not that if you use the dorsal plus with the extra wing, I don't think it's going to break. But sometimes we want to let patients brux who brux. They're maybe not as comfortable. They may actually have jaw problems if we don't allow them to move. And this allows that really nice sideways movement if that's what we want. And especially if you do the EF, you're going to have one that's going to hold off. So nasal patency is perfect for this, opening, minimal teeth, all that stuff. You know, patient dexterity that's really for the older version, because it was so hard for them to get that in that screw if you want them to adjust it. The newer version here with the adjustment in the back, I would probably take that off the list from the Respire end anyway. And I put aesthetics here. I think most people are okay with this, but sometimes the metal intimidates them a little bit. So we're coming down to the last one. We're going to maybe go 5 minutes over, because we're going to talk about what we do after we give them our patients the device in just a few moments. But we want to make sure we allow plenty of time here to talk about maybe I would say an underutilized, underestimated device called the EMA.
Yeah, elastomeric mandibular advancer. That's what that stands for. So it's got a little, couple little hooks. It's made out of BioAcryl. Typically, they will make this out of 2.5 BioAcryl if you don't tell them something different, which is a little bit thicker. It's a lot easier to work with. You know, I mean, think about a bleaching tray, which is nothing. You couldn't, you know, make somebody's jaw move forward and hold it there with a bleaching tray, but this stuff is a little bit more rigid. So you know how the buttons, I think, on there, you know, maybe I'm getting ahead of myself, Guy. What else can we say about the design itself? You know, the upper button goes on a maxillary canine, the lower goes on the first molar. You know, that typically is about 26 millimeters in the average class 1 patient. And then the rubber bands come in light, medium, heavy, you know, firm kind of stuff. So, and you look at, they come in different lengths. So now we have the top and bottom, and we typically start somebody on a 21 or 22, and then we go to 20, and then a 19, then an 18, then a 17. So instead of turning a screw or something, you actually have to take the rubber band off and change it. And, you know, what do you think with this, Guy? We use this kind of the same way we do a dorsal and a Herbst, don't we? Really?
It's somewhere kind of in between, because it does lock you in place a little bit. I mean, you can open some. It's very comfortable. I can wear one of these with my nasal blockage, partly because one thing you didn't mention is typically they'll build up a posterior stops in the back. You can tell them not to do that, but I think it's one of the beauties of this is it builds up in the back, and maybe if I go back you can see it a little bit more. These little stops in the back, which leaves a little room for the tongue. So even though I can't open my mouth a whole lot, I can still breathe through my mouth. And see how thin this is. It allows tons of room for your tongue as well. And so I say it's underutilized because it looks so flimsy, and you think, gosh, is this really going to work? And look, go back to our Phelps slide or the other slides. All we're trying to do is hold the jaw forward. And if we can do that with as little stuff in the mouth as possible, then why not? And this accomplishes that. The thing that I don't like about this is because it's typically made out of BioAcryl, you have to make sure it fits fairly tight or they will pop out of it. And if the teeth are very divergent, they're not, you know, it's hard to get a path of insertion, then it's hard to get this thing to fit and still be retentive. And I would say of all the ones we discussed today, even though I've seen these last years, I saw one that was 8 years old not too long ago, it will break more readily than the other three, I would say. And the class of occlusion, especially class 2 or 3, you have some limitations because you only have so many. I think it's, what is it, 9 links of these bands.
Pretty soon, you know, if you got somebody that doesn't have premolars, right, Guy?
Right.
That distance is closer, and when you start to move them forward, now you're just pulling up and down instead of front to back.
And I will mention that those bands, I would use typically the blue bands, which are the next to the most firm, the clear are the most firm. Those are the ones that typically are the most comfortable, easy enough to get on, but last the longest. Some of the flimsier bands will stretch out. So what do I like about this? It's comfortable. It's aesthetic. I mean, for patients who are concerned, they may be single, what have you, newly married, and they don't want to see their partner thinks that these devices are something weird for whatever reason, they can't even tell they're in for the most part. They're one of the least expensive devices, and you know what? I've had very good success with this device as well. So, I mean, I've had patients with very severe apnea that we've gotten down to very manageable, if even considered apneic at all. So don't underestimate the EMA. Again, don't make the wrong device. It's heavy bruxers and severe class 2 or 3. I would be, and the people diverging, the ones I would steer away from. Other than that, I think you're going to like this device. Oh, the lower molars must. I see up here. I mean, we put that in there. I would hope that we need that brain picture here again. I mean, that's where it hooks on, folks, is the lower molars, and if they're missing, maybe this might not be the device of choice. So, so
you would have figured that out eventually, Guy.
But when you try to deliver it, you'll figure it out real quickly when it pops out every 5 seconds, and you realize, oh, that wasn't very smart. Because ask me how I know. I don't think we'll watch this video, Rich, since time is being a little constrained. But you want to talk about this AM aligner in particular for just a second and why we use it, and then we'll skip over the video.
Yeah, you know, a lot of dentists and I would say patients as well, Guy, are concerned because when I open my mouth and I move my jaw forward and I take my dental device out, my bite feels funny. You know, if we tell people this, look, your bite's going to feel funny. It's not normal to sleep with this big chunk of plastic in your mouth all night, every night, holding your jaw forward. Last time I checked, you know. So we work very hard to recapture the bite. The jaw wants to kind of move down and forward like that, you know. So we tend to create posterior open bites. But since we started making these AM aligners, Guy, where we just put it from canine to canine, we want back and interdigitated. And then we give the patient a few exercises to do. We like this. Make that funny face, pull your tongue back. You can push on your chin a little bit as well. You can put fingers here, thumbs underneath your back and push back and up. So we're kind of counter rotating the jaw the other way. The one on the left there is the morning repositioner. That's kind of doing the same thing where you bite in the premolar area and you're doing that while you push on your chin. So there's a couple of different ways to do this. The important thing is get your patients in the habit of spending 4, 5, 6 minutes in the morning to recapture their bite, and you're going to have fewer side effects and fewer problems.
Right. And if that's not clear, I know we're getting a lot of questions typed in. We're trying to answer them as we go. We're going to stay on and try to answer as many as we can. We'll type some in and we'll answer as many verbally. I'll go ahead and type free consultation. And I know that some of you already done that. We'll be happy to meet with you, our dental sleep medicine experts, and answer any questions regarding this or any other dental sleep medicine questions in a moment. So again, it's going to go just maybe a few minutes over the hour here, but I think it's worthwhile if you'll stick with us to understand you've selected the device. What do we do next? Because it's not just a matter of slinging this device at somebody, and we've got to make sure we achieve our goals. But first, we've got to understand the goals, and the goals are really, there's 3 of them, and I'll just put them up here for time's sake. Is to wear the device, make sure their symptoms are better, and make sure that their airway's better in a measurable aspect. In other words, with a follow-up sleep test. So if they don't wear the device, the other 2 don't matter. So we're going to see them at first, make sure they're comfortable. We're going to make sure their symptoms are addressed, because if they're there because they're snoring and their spouse is saying, you've got to do something about this, we don't address that, they're not going to wear the device either. And then we'll follow up with a sleep test. So we go through this. If they're not wearing the device, we could spend a whole webinar on this. But you know what? The truth of the matter is, the vast majority of them will wear the device. So if they're not wearing it, it's too tight or pushing on a tooth, and we could talk about that.
Find out why. Find out why
and adjust.
That's right.
I mean, it's no different than the partials, dentures, mouth guards that you've done. So, I mean, you all can figure that out. Now, most of them are going to wear it. I mean, 19 out of 20, maybe 39 out of 40, maybe 49 out of 50. But most people, you're going to give it to them. You're going to tell them to wear it. Call me if you have any problems. I'll see you in a few weeks is typically what I do. And then when they come in, is it working? Well, how do we define is it working? We're going to show you that in just a second. If it isn't, then we're going to go through a process where we have them move the device forward over a period of time, maybe a 1/2 millimeter, 1/4 millimeter, 1/2 millimeter, but I would say a 1/2 millimeter is kind of a good number to keep in mind.
Per week.
Per week.
Like that, right, per week.
Over a period of a few weeks, and see how they're doing again. Then you're going to ask them those same questions again. How are you doing? So the question is, what are you asking? Well, that really comes back to a lot of things we're going to talk about in our next webinar at the consult. We need to set the expectation at the consultation as to what we're trying to accomplish. You know, what are your symptoms? And I'll briefly walk you through that in a second. But once that's finished, we're going to do a follow-up test. And so this is something that was the hardest part when I first started, because I didn't know how to know if it's working. I didn't know how to do the follow-up test. I spent hours trying to figure this out. And we'll give you a brief preview of next time when we're talking about the consult. But if you have a good consultation and you sit down with your patients and you say, look, what are we trying to accomplish? Well, I'm sleepy, I'm snoring, I'm waking up at night. Well, we have a system through DS3 for them to actually provide that information via the web portal that we have, so without you even having to spend a lot of time talking to them. And it puts it in this kind of format. So when they come in the next time, they fill out the same information, and very quickly we can see, I know you all may not know what ESS, TSS, but this is sleepiness, and it went down, which is what we want, from 19 to 8. The snoring went down from a 9 to 3. The energy level went up from a 3 to 8, and their sleep quality went up. So if their goal was to be less sleepy and to snore less, and we asked them, do we accomplish those goals after we look at this, then we're done. With that, it's number 2 on the list. If they are still snoring, then we're going to go back, adjust the device some more over a period of time, 1/2 millimeter every week or so, and actually the patient will do that, and we'll have them back in and we'll ask them these same questions. And we've really done a good job, I think, at DS3 of taking a subjective process and making it as objective as possible of system. So
that's a good way to put it, Guy.
Yeah. So now they're feeling better. They're happy. The device is comfortable, number 1. Their symptoms are better. They originally had a sleep test to start with because they have apnea in most cases. We want to see if we're to the successful level. So this is one of the reasons Rich and I are partners, isn't it? Because of the changes in sleep testing.
Is it?
Yeah, because we started talking about, remember originally our whole model, we were going to, sleep testing was a big challenge. And we were frustrated about how dentists can't get their patients tested because they had to go to the sleep lab. Well, guess what, folks? You don't have to do that now. Now you can do sleep tests. You can do it at home. And that was one of the original conversations we had. That
was a long time ago, Guy. I had forgotten about that. But you're right. It was over sleep testing. So
that's why we sat down and we're saying this is so frustrating. And now we do sleep testing at home. Originally, I would do a sleep test at home. If it wasn't where I want it, we'd do another sleep test, another sleep test. And then Rich figured us out one day. Hey, what about instead of doing one night, let's do 2 nights in a row at a different position. And hey, if 2 nights are good, some of these machines will actually record 3 nights in a row. So now what we do, depending on the testing device and the company that we're using to test, if the patient is happy with their symptoms, happily wearing the device, we say, all right, you've moved it a little bit forward. Let's test you right there. Now I want you to move it a little more rapidly forward the next night and test it again. And then if you have 3 nights, you're going to go about as far as you can comfortably and test it again. Then when you're finished on that second or third night, depending on the number of nights, you're going to reverse all the tests, the turns back to where you've been wearing it comfortably for quite a few nights, and then we'll find out. And so in DS3, what makes this really great is we have the baseline number. This is almost 30 times an hour the patient was having a breathing problem or quitting breathing, and now we have those 3 nights lined up. And I know some of these numbers may be unfamiliar to those of you who are new to dental sleep, and we'll have other webinars to show you what these mean. But wow, at a glance, I can see the patient went from 30 to 19 to 8 to 6 events an hour. And so had we just done a 1 night, we'd only have this data. If we'd done 2 nights, we might have had this. And by gosh, look at this. We've got the greatest data here. Now the patient's backed it up to here, and we're going to say, call them up. We're going to make a task, all kinds of systems in DS3 to make that simple. We send them a note that they need to slowly advance it out to this position. And now we're finished with dental sleep therapy. And due to the time constraints, I won't spend a lot of time, but this is how we used to have to do it. We had to go to the sleep center. Patient had to be watched by other people. They had to wake the patient up, adjust the device at night, have the patient go back to sleep, and we can titrate these devices at the sleep center. It's a little more cumbersome. If you're going to do that, Rich, which device do you prefer?
For adjusting at the dental lab?
Yeah, the tap, because since he's too rich, yeah, because you can adjust it. At least the patient can, or the technician can adjust it without taking the device out. So, and this is not what we do that regularly anymore. So I know I've been talking kind of quickly because I'm quicker at talking than Rich is at times. So I wanted to get us back on time. So we're only a couple minutes over. We are answering the questions as we go here too for you. So I mean, I think now you have enough knowledge to go out and start doing this. If you're snoring, make one on yourself. If your team, let's don't wait forever to get started. I think that's the biggest problem we see, is that when we take the hundreds and hundreds of, well, actually thousands of dentists we've trained over the years.
Yeah, just do it. And I love that little slide you made, Guy, where you walk that guy through the, how you screen them. We get them sleep tested. We do the consult. So, we're kind of doing this backwards. We're talking today about which dental device we're making. But, the consult is a part of that. And that's what our next webinar is going to be on, in just a couple of weeks. So we'll hope you can tune in and watch that as well. But yeah, this does not take very much of the dentist's time. You can train staff to do an awful lot of this. And what does that mean, Guy? That means I get a pretty good return on my investment. I don't know about you, but right. I pay myself more than I do my assistant most days. Maybe some days maybe not.
Some days not.
But yeah, we can train auxiliaries to do a lot of this. And I will tell you that it is the most rewarding, meaningful work that I have done in a long time. Right. So.
And these steps used to take hours of my time, and with the DS3 system, because we are using team members, we do have software, we do have systems that make this much quicker. You certainly can do this in well under an hour of dentist time. If you're interested in learning more, again, just type in a consultation, and one of our trainers will talk to you, answer your questions. I will say this, and I've said this for quite a few years now too, and no one's been able to argue in the other direction on this. There's not anything you can do as a dental office. No other service can you add. No other valuable, life-saving procedure can you do in your office that has a higher net possibility for you to add to your bottom line income. It is highly needed. Medical insurance covers a lot of it. And if you do as little as one device a month, you add $20,000 almost a year, $19,000 a year to your practice. And these are not crazy numbers. $2,500 a device, $350 for the lab costs, and even if you're paying someone else to help you with insurance, which we recommend. If you do one a week, you're adding 42. If you do, one every other week, you're doing 42. If you're doing one a week, take 4 weeks off a year, just south of $90,000 you're adding, and you're not adding to much of the dentist time because your team is doing this. And that's hopefully not the reason you do it. I mean, we certainly are in the business to make money, but we want to help people. You have to have a plan to do this. There's a lot of parts, those little steps. We're going to go through the consultation step next time, a lot of steps, but that's all we do at DS3 is help with that. Again, if you have other questions about those steps, anything we've gone over, I think one of the things that's really worrying to me is we do this every few weeks, and we have quite a few people type in free consultation, and we get thank you notes, emails back. Thank you for taking the time. It was, the time was well spent by talking to our trainers. That's all. We have a room full of people that all they do every day is help dental offices with their dental sleep challenges. That's all they do. We're not here doing, that is our service. And if you have questions that we didn't get to tonight, I've got a few we're going to try to answer here in a second. I know we're typing them in. That's what we do. And again, if you want to come to one of our courses too, type in course and you can get $100 off of our normal fee for at least a one-day course. And so I don't know if we have that slide coming up again. So September 12th, we'll be back at it again, Rich. I think kind of, like you said, going backwards, going back to the beginning, towards the beginning, the consultation, which arguably might be the most important step in dental sleep, because if you don't make it over that step, everything we talked about today is kind of useless.
Yeah, and I sure do a lot of these days, guys. So I can shed a little bit of light on that. What do you have to have in order to do that? We're teasing you a little bit there, but I'm gonna tell you what patients are gonna ask, and if you don't have the answer, they're probably not going to start treatment that day. So you want to tune in for that. And you did a great job as usual, Guy, putting this PowerPoint together. I appreciate that. We've answered a lot of questions. There is a couple more here, Guy, on, one was about, how do you know people are really doing better? Well, we went over that a little bit with the subjective test. We showed you how in DS3, we're basically snoring, better, same, worse. Sleep quality, energy level, maybe how many times you get up at night, maybe your sleepiness as well. So I think most people know in their heart, man, I can tell I'm feeling better, I'm sleeping better when I'm using this. And then we do the follow-up sleep test, because I tell people, Guy, that's what helps me sleep better, right? Because I know it's helping you.
So one of the other questions that came through here is, which labs do we use? We work with a lot of different labs, and a lot of labs do a great job. We kind of highlighted Respire and Whole U today, mostly because they have some new innovations, and we try to bring those out to in particular our members that use our system, but also as we do these webinars. And what I really in particular love the new Herbst design. I'm excited about the scale, excited about how much easier it is to adjust. And so that's one of the labs. If you want to know other labs, you want to know anything else about, see some some questions about how do we get our patients tested. We have sleep testing labs that we work with that make the process very seamless. Just contact a phone call if you just want to answer the question, or type in consultation if you have more than one question and want to take some time. This I think everyone should do. If you're not already subscribed to Dental Sleep Medicine Insider, go here. It's free. You're going to get a lot of value out of it. One of the things Rich mentioned about TMD, how the patients often get better. Last 2 months, Jameson Spencer did an article for that answered that very nicely. We have videos in there that talk about dental devices, talk about insurance, all the things that we're going over today.
That's very cool. It's a digital magazine, so you need a flash player on your computer. You just click on the link and you can turn the pages. And what's so cool about it is we have videos embedded in it. You can click on them and see that. Jameson, didn't you love that stuff, Guy? We had the jaw opening and the clicking and the popping and all that kind of stuff. I have to say I learn something every time I read one of those magazines together.
And I mentioned that because if you go there, you can look at the back issues, and as you know, that might have been a little unclear to everybody about how dental devices can actually help TMJ problems. And so if you go back to the back issue, the last 2 issues, there was part 1 and part 2. It really does, Dr. Spencer does a great job of explaining why that is in certain cases. Lastly, this is what we do. If you want to succeed at dental sleep medicine, you need a system and team members to screen, test, treat, and bill your patients. And what we do is we're the glue that holds that together. We help you through education, coaching, software, and support. So everything that needs to happen to make dental sleep a part of the practice as much as you want. Some people, like Rich, want to do it all the time. Other people just want to treat their patients. We will help you all along the way for a very reasonable fee. And again, we're happy to talk to you about that. Just type in consultation, and again, if you want one of the courses, type that in. Here's how you get a hold of us. I think we got answering most of the questions here on typing. I think we've been going along, so I think
there's one in there too, Guy, about cost. You know, what do these things cost? And I would say put consult in there and talk to one of our sleep medicine experts, you know, about that, because you know the lab fees range, you know, $300 to $700 in that range. Guy just told you you can do this for less than an hour of the dentist time. You know, if you have an efficient system and you can do that, so it's a little bit easier to talk to you one-on-one about that kind of stuff. So if you put that in there, we're happy to give you a call.
Happy to do it, and we hope to see everyone to tune in again for the consultation again in a few weeks. Here's how you get a hold of us. Rich, as always, enjoy talking to you. So stay safe out there in Texas, and we look forward to talking about getting your patients involved in the consultation next time. And meanwhile, if we can help you in any way, there's how you get a hold of us. Feel free to call us, email us, and we're here to help with your dental sleep challenges. Thanks for taking the night with us.
Good luck, guys. Hope to see you soon.